thrilled now to be joined by Dr. Randolph Chitwood. We're here at the AATS Mitral Conclave 2015. Dr. Chitwood, who all of you know, is also emeritus professor of surgery and the founder of the East Carolina Heart Institute. Is that right?
I am.
You are that. And today you're going to be giving one of the honored lecture, a journey in mitral valve surgery or something like that. Is that right?
Yeah, I'm going to title it The Long Journey because, remember, it's taken us 40 years to get where we are in mitral valve repair, starting with Alain Carpentier and others. And so it has been a long journey to get more people to repair valves.
Absolutely. You've obviously been one of the pioneers in robotic mitral valve surgery. So where do we stand today with robotic mitral valve surgery?
Technology has improved. We're in fourth generation of robotic device. And I think it comes to adoptability. Large centers who have a large volume of patients and expert mitral valve surgeons are using this device quite effectively, like the Mayo Clinic and Cleveland Clinic and your group in Atlanta and others. So, but the occasional user who's not doing many mitral valve repairs, they really have not picked up the technique.
Randy, which patient would be ideal? So if you're an experienced mitral surgeon, okay, and you're doing robotics or want to do robotics, which patient is ideal to do?
Well, generally they're fairly healthy patients. You know, the average age of our robotic surgery patients was 60 years old, and I've done over 1,000 of these operations. But patients without pulmonary hypertension, without right ventricular dysfunction, without severe coronary disease, even though sometimes we do a hybrid operation with dilating a coronary first. But generally, they can have all complexities of mitral valve disease, but it's the other comorbidities that you want to stay away from.
So what about the mitral apparatus, though? Is it best for a P2, isolated P2? What happens if you've got Barlow's, you've got annular disease, you've got commissural prolapse? That was something I'm thinking about.
Well, I think you're right. I think most people are doing, 80% of this is posterior leaflet P2 disease. But those of us who've done a lot, we've done everything. We've done complex Barlow's, ischemic mitral disease, rheumatic disease, which I wouldn't suggest someone starting with, or Barlow's bileaflet prolapse. But clearly starting with a posterior leaflet and then moving to the anterior leaflet and simple pathology, it's ideal for robotics.
So you'd really, the beginner robotic surgeon, even if they're experienced mitral surgeon, would probably not want to start out with a very complex valve.
That's right. And I don't think you should with minimally invasive surgery. Really, robotics just means a different instrument. The approach is the same as when you use minimally invasive and long instruments. So I think that in beginning this work, people should use the classic sternotomy and get good results in a number of patients and follow their results before they move into these more advanced techniques.
Well, that is the idealized world, but I'm not. I hope that people do that.
Well, that's our job to keep people working in the right sequence. And when we're teaching, that there is a stepwise progression that is most appropriate for these techniques.
So, you're exactly right. What's the learning curve? What would you say would be the learning curve of somebody?
An experienced mitral valve surgeon who is very competent doing repairs. We can get a team after about 30 cases so that they're very facile and with almost the same pump times and cross-claim times. Obviously, it's different if the person does not have the large experience.
Okay, so again, having good experience as a mitral surgeon is really the criteria to build on.
Absolutely. And, if you look at the literature, Steve Bowling's paper, which basically suggests that, you should be doing about 40 mitral valve repairs a year to become considered an expert mitral valve repair surgeon.
Randy, what's the future of robotic? There's so much going on in mitral valve surgery today, transcatheter approach, all that. What do you see as the future of robotic mitral surgery?
I think minimally invasive techniques are are the watchword for the future, whether it is done percutaneously or through small incisions. And still, we can completely reconstruct and re-engineer a mitral valve with robotic and minimally invasive techniques. So I still think it will be here. The devices will be better. But there's clearly going to be a role for percutaneous techniques as well. So it won't take away from the surgical approach. I think that the sternotomy approach will pale in time.
Yeah, well, I mean, you've been a tremendous leader in not only in developing the technique, but educating your colleagues. And so thank you very much for all you've contributed. You're still going to be around. We're not signing you off yet. You get the honored lecture today, but you're going to be around making a major contribution.
I'm as busy as I was when I was practicing every day. And I've done over 3,000 mitral valve repairs. So I'm happy with that.